It is 12 noon Eastern time, and it's time to launch episode 210. We're thrilled today to have Dr. Chris Carson with us to have a chat about the no wrong door, not just a philosophy, but putting it to action. And how does that work? Chris, you were last on with us 4 years ago when you and I did something similar. Laura Evans was supposed to be our host today, but is actually had to be on a plane. So I'm David Covington. I'm with Behavioral Health Link and Recovery Innovations, and thrilled to guide us through another crisis jam. We've had 500 unique speakers as a part of the program over the last 5 years. And if you, it's alphabetical, so look for your name. You'll see Chris Carson's name. He was already up here from having been a featured presenter back several years ago, again, as I mentioned. But if you would like to speak and you haven't, you don't see your name up here, you have an idea that you would like to advance, or a topic or speaker, let us know. We just met with Chris Hauserman from Michigan about an upcoming debate that we've now put on the schedule. If you go to talk.crisisnow.com, you'll see everything you need to know about supporting being a part of this community. And we now have a new option. So there are 3 ways now to participate in the Crisis Jam. Last week, for the first time, we did a live stream on YouTube. If you've got challenges with government Zoom, or for whatever reason, it's a better option for you to check in with YouTube. It's actually, you're streaming live now on YouTube. And we had about almost 40 of you last week who joined us in that fashion. Of course, what we hope you'll do is join us with this Zoom community where you can take part in the chat and put your questions or comments or thoughts in, get an access to the direct links that we share, participate in the poll, and more. All of that comes from signing up for our weekly newsletter, registering for the weekly Crisis Jam. There are well over 2,000 of you who are now in that community. You'll remember we had to start over back a few years ago because of a hack of the community. But we've gone from that original. I think we had almost 5,000 in the community, and we're back up above 2,000 now. You'll also get access to, not only do we live stream on YouTube, but we also upload the program to YouTube separately, so you can watch it later if you missed it. Now, last week was our first live and on location event. Justin Shelby, Kristen Ellis, and Karen Jones all supported, and we were so thrilled. Kevin Curtis was our host and walking us through the fabulous new Kim and Carolyn Gardner Crisis Care Center in Salt Lake City, a well over 70,000 square foot, no wrong door, law enforcement drop off with both observation and inpatient units to support that community, which will be launching soon. If you didn't see that program, I really encourage you to go back and get a chance to see that. And we've got someone that we need to mute there. Thank you. In addition to the live and on location events, and we're hoping to do those quarterly this year. So if you've got an amazing program you'd like us to come out to, please let us know. But we're also attempting to increase the engagement of the program through ongoing debates. The monthly focus is our goal, and debate number 6, mobile crisis should always be dispatched by the local 988, is coming on April 16th. Justin Chase will take the affirmative. Preston Looper, who worked closely with Matthew Goldman on the amazing SAMHSA survey around mobile crisis last year, will take the negative on that. So we're really excited about that presentation. Debate 7, all states should enact legislation that includes a 988 fee, similar to how we pay for 911. NAMI and NASBID worked together on model legislation that many states have already used to move things forward, and Hannah Wesolowski from NAMI will take the affirmative on that. Tom Betlock will take the negative. I mean, he's not going to say we shouldn't fund 988, but he's going to say there are other ways to do it. Former Medicaid director in Arizona and head of our mental health program at that time. We'll talk about the way that other states like Utah and Arizona have done it. A month ago, we had debate 5, a really great program with Margie Balfour and Travis Atkinson on crisis facilities should receive voluntary and involuntary referrals, and Margie took the affirmative on that. The most common response was yes, 36% Another 33% said definitely yes. So the vast majority of our audience was on the side of it should be both voluntary and involuntary. And that's required and part of this no wrong door approach. Travis technically got you, Margie, because he moved a few people. Again, the way we judge who wins the debate is we take that pre-show survey and we compare it to the post-show survey. And it's really hard when the audience comes in overwhelmingly on one side, and a few votes actually trickled back the other way. But for those of us from the Arizona model, we can't see it anyway differently from that. And I want to go into that just a little bit to set some context for today's episode as we talk about why that involuntary, involuntary, and that no wrong door approach are important to a crisis care system, especially for those at higher need. So we've got an over-under. We're not going to do this formally. We're just going to talk this through a little bit. But we did this in Amsterdam at the Crisis Now 3 Summit last summer. Daily 988 volume averages 14,000 calls, texts, and chats, and it's growing. But how many people are in the hospital ER every day for mental health, substance use, and or suicidal crisis? I'd love it if you just drop in the chat what you think is the number. And then we'll have some folks respond with over or under that number. Let's see what we get in the, how many a day? Michelle Bauman says 5,000 a day. We've got 2,500. Let me give you just a little bit more information as we go here. There are approximately 140 million total visits for all causes to emergency departments every year. So that means that every day, what is 140 million divided by 365? I think it's not quite 400,000, somewhere in that 350 to 400,000 people a day for all causes. About 8% of those a day are related to heart disease. So the answer, if it was heart disease, would be 30,000 a day. Most of you are guessing in that 5,000. But the 10% that Ralph Nieder-Westerman is talking about, that's actually close to what we think. The CDC believes that 140 million people visit the ED, and approximately 10 to 12% of them are related to mental health, substance use, or suicidal crisis, which is, it's actually just a lot higher than we would ever think. 44,000 every single day are in an ED. They got there by calling 911, 988. They walked there, went in there directly, host of ways they got there. Many of them got there in the back of a patrol car. And if they got there in a patrol car, it's very common for police to stand around. Sometimes they call it wall time. They just wait, and they wait for hours or they wait for days sometimes as individuals get caught in those systems. So the idea of the no wrong door to bypass that is really important. In the US, those in a crisis are often in hospital ERs for days without active treatment, a practice called psychiatric boarding. So this leads us into this week's Crisis Trivia Hot Seat. And it is an international question. This challenge of individuals in higher level of need for crisis care being caught in this pinch point of a hospital ED isn't something unique to the United States. It's a worldwide phenomenon. But in this particular country, ramping refers to a prolonged wait in the transporting ambulance before even entering the hospital ER. They don't get to the hospital ER because of legislation that's been passed there that they can't be in the ER, but for a certain number of hours. Again, an effort to get around boarding. So they sit outside in the parking lot in an ambulance. In what country does this practice occur due to a lack of available beds or care areas open in hospital ERs? Is that A, Australia, B, Chile, C, Mexico, or D, the United Kingdom? Now, as I'm looking at the results coming in, a lot of you are saying the United Kingdom, and we did show a video in the pre-show a few weeks ago about the significant challenges with psychiatric boarding in the United Kingdom. And the interviewers from the press were shocked that the hospital would even dare open their doors to show how significant the challenge was. But the answer is not the United Kingdom. We're actually seeing the survey start to switch a little bit. Australia is taking the lead. We'll give a few more seconds for people to vote. Were you surprised by this ramping idea, Chris Carson?
No, I think it's kind of typical. It's not in a place like Australia. I think that's not an atypical way to do it. I mean, it's not that different than thinking they should wait in the back of a police car. It's way more
Right.
humane,
Right.
way more, but not really any different in my view.
Well, and you were talking about our first efforts in Arizona. People would be waiting in a police car for 90 minutes. In December of 2022, and the answer is Australia, South Australia reported ramping took place on average 100 hours per day in the region, that individuals were waiting in the parking lot, in an ambulance, in a queue to get inside the hospital ED. Mental health is critical in fixing delays where people get stuck waiting for a service. And I went back and watched the episode, Chris, that you and I did together back in 2021. And it really reminded me of this quote, some of your comments. We've talked about the Crisis Now paper that came out from the Action Alliance in 2016. That really came from this quote from a person who was part of our crisis groups survey group. One of the individuals made the statement that mental health services typically have been organized around as providers, our Monday through Friday, 8 a.m. to 5 p.m. convenience. But she said, that's not our convenience. Our convenience is that a crisis has no schedule. So Chris Carson, thanks for joining us. Tell folks a little bit about who you are and about your background. And I'm going to take the slides down. We've got this first one here. Go directly to, not to jail, but to the hospital. Chris, you are really the primary architect of a no wrong door model that's not just a philosophy, but something that has teeth. Talk about that, Chris.
Well, thank you for having me, David. It's good to be here. I think the way I would describe myself is I'm a psychiatrist. That's the first thing I would say, because that matters in this discussion. Secondly, I was a hospital psychiatrist, an emergency room psychiatrist. So I started my career in a large ED with a little psych portion. And so that's really where my world that informed my world dramatically. The county hospital emergency department. And knowing in there what we were capable of theoretically in the system and how unavailable it was in the moment to people when they needed it. And how frequently, maybe even the rule, I used to call it a cattle chute. All I could really do is look at somebody and say, yes, hospital, no hospital. And if it was no hospital, it was good luck. And if it was yes, hospital, it was let's find them a bed and get them in the hospital. And that was kind of how we functioned. And so many people, I think that I felt like the majority of the people needed something in between that. And so that was really where it all started. I think also in there, because we did take involuntary drop-offs and voluntary drop-offs, I recognized and continue to believe that there's not a lot of difference between the two in terms of the clinical need. It is more a legal situation about getting them into treatment. So clinically, I decided, and I made my mind up that there was really no distinction between them clinically and what they needed. Therefore, they didn't need to be in different spots. But what they did need, and I guess then the final part of that was, I felt like if we were really going to get recovery, we had to engage them, and we couldn't rely upon involuntary methods unless we had to. So we made a real effort, and that's all kind of flown through all these years, but to take somebody, maybe they came in involuntarily, but quickly as we could move them to voluntary and mainstream them, to use an education term. But that was the route we felt like towards health.
Yeah.
Ultimately.
Chris, this pathway that we've got on the screen, where regardless of the sort of the referral source, for those who land up needing something more than mobile crisis or communication with someone over a phone or chat or text, they land up being shunted through this hospital ED. Talk a little bit about your view of medical clearance.
Well, if you go back to the left side of your screen, what do they need? That's the question for me. The driving question is, what do they need? What they need is specialized mental health intervention and human touch. So, and possibly risk management. That's the other real reason that people come, I think, into a hospital is for risk management, but also they need more specialized treatment. Rarely is a hospital ED prepared to do that. So I felt like from the beginning that unless there was a known medical like reason to go to the hospital ED, why shouldn't they come directly to psych? And know that that was initially in the context of a major county hospital that had a psych portion and an OB-GYN portion, all the various specialty portions. And it was really the discussion was, do they need to go through the medical ED or do they come directly to psych? And in the vast majority of people, we had them come directly to psych. And that seemed to me the more humane and the more efficient, but also I mean, I don't know who's been in an ED. I don't want to go to an ED if I don't have to go to an ED. So it felt like we were diffusing the situation, intervening much quicker.
And when did this idea of law enforcement skipping the ED and going directly to the crisis center, how did that develop? And what were the early challenges or ease? How well did it work and how quickly did it develop?
It developed really fast in the sense that the real problem was I willing at that point to take the responsibility for them coming straight to me, right? There's a risk question there. It's like, do you really want these people on? Isn't it much better if they have been evaluated, had labs done, and won't you feel much more comfortable and all that kind of question? And I just decided that no, I didn't, and that we could take them, and we did. The challenge always becomes some people need to be in the medical ED. And so you have to have a real free movement back and forth. It is not a failure to send somebody to medical. I mean, that I could look at them in psych, send them to medical. I needed to be able to do that and did. But the other side of that was a lot of people went to medical and needed to come to psych. So we just arranged it where that was a freeway and there was not any barriers and it worked. And then we watched the data for that and realized that the proportion of people that needed to move on that freeway from us to medical was minute.
Yeah. So
Minute
Chris,
meaning 5% or something.
well, that was going to be my question. So in a normal system, everyone needing higher level care is screened first. In this system, it's just reversed that the clinical medical staff at the crisis care center are determining if someone needs more stabilization in a hospital. And in your experience, it's about 5%. So how does that work? You land up doing what with those 5%, and what's their journey?
That depends on the situation that you're in your community, right? Are you attached to a medical hospital? Are you not? You have to work that out, and that's different everywhere. But you need to be able to quickly and efficiently transfer. The other real challenge is your staff. When somebody peers, one of the, you've got a few like really critical questions right there in the first moments. One of those is medical. What is their medical stability? What is their situation? And so you've got to focus. You can't like delay that, right? You can't say, well, let me get your paper signed and we'll get you settled in and get you comfortable, get you a little Coke, whatever it is. No, it is like immediately you've got some questions to answer. And one of those is their medical situation.
Chris, so as we're talking about what makes this work, it sounds like one of the key elements is the medical psychiatric leadership, because there is a little bit of a different attitude or culture around risk and rolling up the sleeves and jumping in to talk about your medical leadership. Of course, you guys brought in Margie Balfour as you got up and running. What has been key to you in finding the right psychiatric leadership, and how important is that in this model?
It's really important. I think it's underappreciated at times, but I do think that was critical to because we felt like in order to be, as you describe it, no wrong door, we had to take as much responsibility for the situation as the police took. See, that's what usually the police have no option but to be involved, right? They get involved, they're involved. We felt like we needed to have at least that much involvement and skin in the game. So we would, and that requires a certain medical capability. It requires a certain medical leadership and a certain ability to contemplate those medical issues and the seriousness of them. So the medical leadership was, I think, very, very important to us.
I think one of the things, and if we go back to that Salt Lake City program as they're getting up and running, this will be on par with the size and scale of the Arizona-based crisis facilities. What does the flow look like in these programs, Chris? I think people might be surprised by the throughput and volume of individuals that land up having their needs met in these kinds of facilities. What does that look like in your urgent psychiatric center in Central Phoenix?
The flow, in some respects, I actually went eventually and got my green belt in Lean Six Sigma because so much of these facilities are about throughput. And that's a very different mindset than most providers have. You build a relationship and you perpetuate that relationship. Say, Community Mental Health Center does that very well, right? Or FQHC. That was never our intent to create a relationship. We were there to assess, treat, stabilize, and then place them with somebody that they could have a long-term relationship with. So throughput was critical. When the system either bogs down or the system doesn't support that throughput in whatever way, or your own staff don't kind of lose track of the game and don't realize it's about throughput, then things bog down. And if the system ever bogs down, then again, you're turning people away at the door. And that was one of our priorities, was never to say, it wasn't just no wrong door, it was never to say no.
Right.
And so we couldn't do that if the system bogged down.
Chris, when I first came, you and I were both with Magellan Health before you moved to Connections and I moved to Recovery Innovations. And at the time that I joined, we had a crisis facility with some significant capacity, but they didn't operate according to this no wrong door. And it was common for that facility, also in Central Phoenix, to admit maybe 0 people a day, maybe 1. On a rare day, they might admit 2, even though that was I think it was a 30 some odd bed facility. How many are you likely to admit today across your facilities, Chris?
David, I have no idea. I would guess in Phoenix, it's probably, we see probably 1,200 people a month.
Yeah.
Maybe.
So you're talking about 30, 40 a day.
Absolutely 30 or 40. I think it's actually more than if you consider the walk-ins, the urgent care,
yeah,
some of that stuff. It's and it varies, but it's a lot. But that was the intent.
And Chris, how many of those are dropped off by a police officer?
That has also varied over the course of 15 or 20 years because, it has to do with the police culture and all these kind of things, but probably a third to a half.
Yeah. Yeah.
That's a guess right now because I don't have the data in front of me, and it has varied over the course of 15 years.
When Margie and I made that video together back years ago, one of the things she said is you can have 5 cop cars show up at the same time. And that seemed like a little bit of an extreme. And then we started doing the same practice. This is our facility in North Carolina where we had 5 police cars show up at the same time. Once you take that approach, though, Chris, and you have that kind of flow and that kind of volume, what does the acuity of that population in your program look like? Compare it to other crisis residential or even psychiatric inpatient or detox programs. What does the level of that acuity look like? And how do you manage so people are having their needs met and it's safe and a recovery focused environment?
Oh my goodness, David. We define our services by acuity level, really, right? So if you're in the 23-hour OBS unit at UPC in Phoenix, let's say, or any facility, for us, that means you meet at the first kind of initial assessment, you meet inpatient criteria. So you're a danger to self, danger to others. We don't want people in the 23-hour OBS unit that are out of their Prozac and are feeling a little down and just want their Prozac refilled at home. That's how we distinguish between urgent care and 23-hour OBS is an acuity distinction, with somebody being brought in by the police on an involuntary hold, kind of prima facie being That's inpatient criteria, right? Until we assess them. So they come onto the OBS unit, but we try to maintain the OBS unit as a high acuity people who, need the structure of that kind of unit, the lockedness of that unit, the safety of that unit. That's really what the 23 OBS unit's for. If they don't need all that, then they should be in the urgent care.
Yeah. And what does the staffing look like for that kind of program, Chris? Because it is different. That program we were referencing that was admitting 1 or 2 people a day, it's a different level of psychiatric on location, et cetera, different level of medical nursing. What does a program like Salt Lake City, what are they going to need in order to pull this kind of flow off with this level of need?
There's not really I don't believe there's a staffing like magic ratio number kind of thing that you use. It really varies by, again, facility, community, what you're doing. What I think I would say to that question, so we struggle with that. As we go to new places and different places, the staffing becomes a discussion. It's kind of like your debates that you're having frequently. There, you have to live in the tension of that. There's not really like a magic number, but I think what we have found and what we believe is the tech. You start with the techs. The techs are incredibly important, and so many people see behavioral health techs as kind of almost paraprofessional kind of. I think techs are critical, and I think a professional track for techs and a kind of a professional ethic, which they do their job the best. That is really critical for the safety of this facility and the running of the facility. The other's the medical, including nursing. And then you've got to have the really high quality social services kind of thing that so much of discharge has to do with psychosocial and arranging appointments and all that kind of stuff. So it's kind of about keeping the tension on all those points. But certainly at the 23-hour OBS unit, safety is priority, right? It's about being safe.
So that staffing also gets into the facility and the flow, all that gets into the rates. I think I had hoped to get into the financing. Representative Steve Ellison has done a lot with it, including with the legislation and with the health plans. But we didn't get to the rate for that observation program in Utah last week, but it's almost $1,400 for someone to be served in that. And I think people are a little bit taken aback by that. But the impact of these programs, it's an inpatient style program with inpatient rates. The savings and impact comes from the length of stay and the throughput of this, Chris. Any comments on what it takes to fund a program like this so that it can be sustainable and meet the goals that you're talking about?
I think one of the things that we have to discuss more is you have to define the service, really, right? I think that's one of the areas that we're confused in right now is to have a really well-functioning crisis system in the future, there should be multiple types of services in that, right? There are questions in the chat about crisis residential and coming out of a hospital into something before they go home, and all of those things are needed in order for a system to really work well. What I described just now in the 23-hour OBS unit is the highest level. It's a medical nursing. I mean, 24/7 medical nursing. That is not. It is a very specific kind of service that is also very expensive. So it's not like we would never have, for instance, a nurse practitioner or a physician come through and do rounds in the morning at that level of care, right?
Right.
So once you define the intensity of the service, then you get to the rates.
Right.
And I think people sometimes don't connect those totally, but clearly it is a challenge to run a facility at that intensity financially, staffing wise, every kind of wise, right? But it's also, that is what that level of care is for us.
Chris, this was the slide we used back when we talked 4 years ago, just to show, and this was the base. There have been other facilities added since, but the way that Arizona built the locations of the facilities to maximize a quick turnaround for law enforcement and for the public. Tom Betlock has talked about when he was the Arizona Medicaid director, despite the cost of these facilities, that there was a $2 return on either on every $1 invested in these programs. So let's go to our roundtable section. And Chris, you talked about the definition of and the sort of making sure we're defining these services. Margie Balfour, you're talking about the new SAMHSA guidelines and the high intensity behavioral health emergency center, high intensity behavioral health stabilization components. Margie, you want to talk a little bit about just build on this conversation and your reflections?
Yeah. Yeah, so, Chris and I have worked together for a long time, and to be able to do this work to take everyone, I think it's, as we've talked in the debate, is really important. Um, and then, the medical leadership component is critical for some of the things he was talking about, like having those relationships with the emergency rooms. I mean, part of our model is that our medical directors meet with the ER that's, next door to us, for example, down in Tucson, every month. Like when we first started there, the relationship with the ER was horrible. And a lot of distrust, a lot of you're trying to dump on us, and starting to have that level of medical leadership where it's like, don't get into disputes in the moment at 2 in the morning as you're arguing and put the patient in the middle. Like, save it for and send it to your medical director, and then like let us go over individual cases. And we really took, Chris mentioned like we did our Lean Six Sigma Green Belt training together. And it really takes a QI approach to managing these. So then you go over those cases and go,
Right.
oh yeah, like, maybe these group of people we didn't need to send to the ER, and then the ER would help us make a better protocol, for patients, with whatever that condition is. So, that's kind of the approach you have to take in terms of, working around it. I don't even like the term medical clearance. The field is really trying to shy away from that term because it doesn't mean anything. The question is the person medically stable? And then if they do need to go to the ER, they don't go for clearance. They go because they have a specific thing that we need
Right.
evaluated and treated.
Right.
And we take them back. That's the other thing. No one likes to feel dumped on. They, we send people, and then they know that we're going to take them back. And then they send us people. And we know that, if some medical issue happens, that they're going to take them back. So that relationship building is key. Um, and with the police, that no wrong door concept is that, the police shouldn't have to be deciding where to bring people. Um, and we kind of like, it's really unclear, it's sort of a gray area as to whether these emergency behavioral health centers are like governed by the EMTALA law. Like if they're attached to an emergency room, they probably are. If they're
Right.
freestanding, are they? But really, when you talk about no wrong door, because everyone talks about it, no one defines it. And to me, I think it's basically meeting the spirit of that EMTALA law. And
Yeah.
with that, and if you're not familiar with that is, that's the Emergency Medical Treatment and Active Labor Act. Because back in the day, a pregnant woman would come to a hospital in labor and they'd say, you have the wrong insurance, go to the poor person hospital down the street. And so they passed a law that says you can't do that. If someone lands on your doorstep, you have to take responsibility. And so you have to do some kind of screening and assessment, determine if they have an emergency condition that needs to be stabilized, and then you can transfer them, but you have to take that responsibility, and you can't just say go away, go get in the back of your police car and drive off. And so that's really, if you're no wrong door means that you take everyone who lands there, you take responsibility, you have a sense of ownership. And if they need to be somewhere else, maybe a lower acuity place is a better place for them, or maybe they need to go to the detox place across the town, or maybe they need, a medical issue, that you take that responsibility and then you safely get that person to where they need to be.
Margie, we actually had the trivia question on EMTALA last week when we were touring Salt Lake City, but I'm going to take this phrase and we're going to put this on t-shirts. The no wrong door means the spirit of EMTALA. Love that, Margie. Thank you. Chris, one thing you would encourage facilities or states programs that are wanting to take this on, what do they need to do first?
First, I believe that the system should always kind of follow the patient a little bit. And so you've got to deal with somebody that's in crisis. You can't build all of this around it for the like lesser acute and have this massive problem in the EDs and boarding and access to care. And what ends up happening when you don't start kind of at the beginning of the tangle, like with the crisis, in my opinion, is you end up not ever really solving the problem, and you continue to have people that are in beds that don't need to be in the bed. You have people that need the bed that can't get in the bed. You have people in the EDs that don't belong in the EDs. You have all of that occurring because that's at the eye of the storm. So you have to solve this from the eye of the storm and then work out towards the lesser acute situations,
Yeah.
which frankly our systems are better at dealing with already, in my view. So
Chris,
I think that's how I would start.
hey, great. Thanks so much for your leadership and for being on the program with us. Terrific.
Good to be here.
Dr. Richard McKeon, it's time for the SAMHSA update, but you've been down to Margie's program in Tucson and visited a number of these No Wrong Door facilities. Any reflections as you move into the SAMHSA update?
Yeah, I mean, it's wonderful to hear about. Chris has been such an influential figure in the development of these models and these kinds of services. So I've not heard him talk before, so I was very glad to have the opportunity on today's jam to do that. And I love the conversation, about, both about police drop off, minimizing police involvement, not relying excessively on police to be your transport, service, and then, risking potentially adverse outcomes. But also the appropriate use of the emergency room. And there we also need to pay attention to what happens after somebody leaves an emergency room.
Right.
We'd love to, keep huge numbers of people out of the emergency rooms, but we know people at risk for suicide and other behavioral health crises some number of them are going to end up in emergency rooms. And then we need to make sure that when they leave those emergency rooms, that there's follow-up, that they are connected to services, that they're not just left to fend for themselves. So I think this idea of no wrong door, of meeting the person where they're at and staying with them through their healthcare journey is just of tremendous importance. So related to the promotion of an expansion of these important models for a transferred crisis care system, last week SAMHSA had a policy academy, in New Orleans, with a number of states. It went really well. The policy academies we did with last year in Tucson it's an important instrument for SAMHSA to be able to provide more intensive technical assistance to states and other communities to help transform their crisis system. Just one or two other things. The Suicide Prevention Resource Center just released their state infrastructure success stories, and a number of these success stories involve crisis services. So would urge you to check that out. Pardon. And then finally, I just wanted to mention that within the U.S. Department of Health and Human Services, the project management group for the National Strategy for Suicide Prevention is continuing to work on the issue of implementation of the national strategy in coordination with the National Action Alliance for Suicide Prevention. We'll be meeting virtually later this month and in person next month. And we've been working intensively on a scoping plan and monitoring plan to help us do a better job of tracking and what's happening and what's not happening compared to past iterations of the national strategy. And this is something that multiple nations have found over time. You can't just issue a strategy, send it out there, and hope that it gets worked on. You need to be tracking on it in a pretty specific way. So we're looking forward very much to this work. So thanks for the opportunity to give the update, David.
Thanks so much, Richard. Now let's go to, we start with the feds. Let's go to the states. Christy Malik is giving today's NAJBID update.
Thank you, David. And I just wanted to highlight Richard and the SAMHSA's 988 and Behavioral Health Office. Thank you so much for the incredible work that you and the SAMHSA's office has done. It's really transformed the 988 and crisis care continuum, which really has provided that foundation to have that no wrong door approach. And Richard, as you said, with follow-up care being one of those critical instruments for the crisis care continuum. So just again, want to acknowledge your hard work. So for this week's NAJBID update, I just want to highlight a webinar that NAJBID and Vibrant is co-hosting. That is focused on Washington State's Native and Strong Lifeline. That'll be this Friday at 1 p.m. Eastern Time. We are so delighted, thank you. So we're very delighted to have Senators Orwell and Dhingra, who are going to open the webinar, sharing their reflections on the legislative process and how they secured funding. So to have a dedicated line for Washingtonians, Native and Indigenous people. Then we're going to hear from staff from the American Indian Health Commission. They're going to highlight advocacy efforts that help supported the passage of the Native and Strong Lifeline. And then we are very delighted to have Amanda White Crane and Levi Van Dyke from the Volunteers of America Western Washington Contact Center, and they're going to really highlight their development, implementation, and operations of Native and Strong Lifeline, particularly how they built the trust within the community. And one of their strategies was having designated tribal counselors who really understood the history of trauma for their community members. So my colleague has dropped the Zoom registration link into the chat. So if you can't make the webinar, the recording and PowerPoint slides will be available on Vibrant's website. So David, I'll turn it back over to you.
Great, Christy. Thanks so much. And that brings us to our state update. And today we've got Stephanie Pasternak and Daniel Herron from both NAMI and Vibrant. And just a reminder for everyone, the way that 911 and the thousands of PSAPs are funded across the country is a surcharge of $1 to $2 per individual to make those services happen. Those who are following the model legislation, we've now got, what is it now? What are we up to, Stephanie? Are we at a dozen states that are funding 988 through a fee?
So we actually have 10, and I'm sorry, my video is not working today, but we are at 10 with a fee, and yeah, also 5 that have a reoccurring state appropriation as well.
Yes, and you talked about that shift in the map. We're going to get that changed for, this is still showing that old approach of partial. Your color green now is for the recurring revenue or the recurring funding. And those states, if I recall correctly, Stephanie, it was Arizona, Utah. What were the other ones?
Yeah, Kansas, though that appropriation will expire next year, but the other two are Georgia and Florida.
And Stephanie, before you get into your update, one quick question. Abby is asking that $1 to $2, is that a annual thing or a monthly thing?
That's a monthly thing.
Great. So give us the update, Steph.
Sure. So I'm going to go through a couple states, then I'm going to turn it over to Daniel at Vibrant for a few more. And actually wanted to start in Florida. So there's a new set of companion bills there that would codify 988 as being an official part of the crisis care system under the Florida Department of Children and Families. And the purpose of this is really to make it easier to kind of fund 988 in the long term. And that bill also would call for coordination of calls between 911 and 988. And then I will say there's no funding in that bill. But again, it's something that will make the budget process easier for Florida moving forward. But on the actual funding front for Florida, they already have a reoccurring state appropriation of $2.6 million. And in good news, the Florida House budget was released today, and that includes an additional $3.3 million on top of that pre-existing appropriation. So shout out to all the Florida advocates on the call that have been really pushing for funding there. And then I'll move on to Texas. As a reminder, Texas has pending fee legislation in their Senate, and now there is a House companion version. And the exciting thing about the House companion is that it has a majority party Republican sponsors, which should improve its ability to move forward in the legislature. And with that, I'll turn it over to Daniel for a few more updates.
Great. Thanks, Steph, for those great updates in Florida and Texas. Just a few more. I saw that Shelley Delaney from Alaska put in the chat that Alaska House Bill 138 was just introduced last week. That bill would establish a 98 cents per month telecom fee, and it would also create an account. It wouldn't be a dedicated trust fund, but it would be a separate account to hold the revenue from that fee. It's currently in the Health and Social Services Committee. It's not had any committee hearings yet, but it is pretty freshly introduced. So we're tracking that and really excited to see that just starting in the process. And also an update out of New Hampshire, we see Senate Bill 255. It does establish a fee and a trust fund, and then it would also authorize special 988 license plates that could be sold in the states, and then the funds from those go into the trust fund. That bill and the 988 fee on that bill is it hasn't been disclosed or decided on yet, but it just opens the door for that. It passed out of the Senate Finance Committee with a unanimous vote. I believe that was last week, and it's now scheduled to go to the floor of the full Senate on March 27th, which is tomorrow. And then finally, one more update just out of North Dakota. We see North Dakota Senate Bill 2145. And there have been several pieces of legislation in North Dakota right now, but one that I'm showing an update on today has to do with civil liability for the employees and contractors that deliver the services for 988, 211, and the 911 system. It specifically protects folks from civil damages when they're rendering services in good faith, except in cases of willful misconduct or gross negligence. This bill has made it all the way through the process and was signed by the governor on March 18th. So that is great news out of North Dakota. With that, just want to share that there are 45 states in legislative session right now. A lot of things happening across the country, and we're keeping track of all of it, and happy to share at our next update on the next Crisis Jam. I will see you guys next, and thanks again.
Thank you so much, Stephanie and Daniel. And that North Dakota legislation contemplating protection of civil liability for crisis workers, reminiscent of the path that Rep. Orwell and Washington State have been contemplating. So great stuff. And that brings us to our data corner. And Ted Lutterman, you're going to introduce our guests for today.
Thank you, David. Yeah, I'm Dr. Goldman asked me to help organize the data corner while he's out celebrating the birth of his son. And in preparing for it, I was looking at some of the recent research and came across some really interesting work identifying a high-risk community that I haven't ever seen discussed on any of the crisis jams. And not only have our speakers today been studying the crisis needs of construction workers, but they've also been working with their industry to start addressing these issues, including identifying 988 and crisis services to help get out to their members. So today they'll discuss their research and also maybe some ideas on how 988 and public crisis systems could collaborate with their industry. So I'm pleased to introduce William Harris, who's the research analyst at the Data Center for Construction Research and Training, where he's worked for 4 years. He has a master's in in demography, and he led the development of the manuscript we'll be talking about today. And Dr. Amber Trueblood is also with the center, and she's passionate about using surveillance data to identify occupational injury trends. She has a doctorate in epidemiology and environmental health and a MPH that focused also on behavioral health from the University of Texas. So William and Amber, please go ahead.
Awesome. Thank you for that introduction, Ted. And then apologies about the lack of camera. My computer is unable to connect to my webcam at this time. But my name is William Harris, and I'm here to talk about suicides in construction, covering our recent publication addressing the topic, as well as highlighting some of the additional resources and information that we have at CBWR, the Center for Construction Research and Training. In the CBWR Data Center, we regularly research mental health outcomes for construction workers, examining anxiety and depression, workplace bullying, and in our paper recently published in the American Journal of Industrial Medicine special issue, we examined deaths by suicide among working age, those who were aged 16 to 64, construction workers in 2021. Next slide. By utilizing data from the National Vital Statistics System multiple cause mortality file, which has descendant data by usual industry and occupation, we were able to identify construction workers along several key demographics, including sex, age, race, and ethnicity, as well as education and marital status. In 2021, there were 5,213 suicides among working age construction workers, which accounted for 17.9% of the 29,153 suicides among all industries that we observed that year. The suicide death rate for construction workers examined was 2.4 times higher than that of all industries, 46.1 compared to 19.5 suicides per 100,000 workers. Though this is primarily driven by the higher ratio of males in the construction workforce, who historically have a higher likelihood of death by suicide. But when we look specifically at suicides among males, we see that construction had a 68% higher rate of suicides compared to all industries combined, 50.5 compared to 30 per 100,000 male workers. For women in construction, they had a rate of death by suicide that was 23% higher than the rate for all industries combined. And notably, both of those findings were statistically significant, meaning that the difference in the rate of deaths by suicide was not due to chance variation. With the aid of these demographic details, we were then able to identify groups of men and women that had some of the highest rates. For both males and females, those whose highest level of education completed was high school or equivalent, those who were single, and workers aged 55 to 64 years old had the highest rates of suicide. Among men, those who were non-Hispanic and those who were American Indian or Alaskan Native additionally had high rates. For males in construction who were single, the highest rate of death by suicide among construction workers, the rate was 1.8 times higher than all single males in all industries. For women in construction, those whose highest level of education completed was high school or equivalent had the highest rate of suicide among women in construction, which was 1.3 times higher than the same education group in all industries. And then we additionally looked at occupations among male construction workers. When compared to the already high rates within construction, some occupations had even greater risks, those being iron and steel workers, who had a suicide rate 2.3 times higher than all males in construction. Welders and brick masons were also at a higher risk of 1.7 and 1.6 times the overall rate. And then laborers, one of the most populous occupations in construction, had a rate of death by suicide 1.4 times higher than construction overall. And accounted for 29.4% of suicides in construction observed that year. And I'll go ahead and pass things over to Amber to continue with some of our other resources.
Hey, good afternoon. I know 5 minutes to get through a lot of data, so I gave most of that time to William. I just wanted to highlight why we're really interested in mental health within the construction industry, specifically looking at CDC high-level manuscripts. I put one in the chat to address the question on law enforcement. Construction leads and suicide and overdose death rates when broken out by industry consistently, and we really wanted to understand why. And so that suicide manuscript William went through highlights just that first level overview, trying to understand those demographics there. CPWR, as mentioned, has several resources addressing mental health in the construction industry, including resources for suicide deaths and opioid overdose deaths. We specifically have a significant problem with opioids in the industry, so that's where most of those are going. That's linked here in the PowerPoint, as well as our Reason newsletter. That highlights research coming out that addresses the industry needs. It's supposed to be very positive. We hear a lot of negative about suicides and overdoses, but not the good work that's being done. So that newsletter is actually focused on the positive. And lastly, I just want to highlight we have a lot of resources available in addition to those within the data center. Some of those were linked earlier at the start of the presentation. And I'm not going to go list by list because you guys can click on those. But if there's something that is missing that you think would really help you do your job, please reach out directly to us. And that's our end goal here at CPWR, is to prevent these injuries and fatalities that result from suicide, overdoses, and of course, at work fatalities due to other causes.
Thank you so much, William and Amber, for this important work. So that brings us to our last segment, and Stephanie Hepburn, tell us about this week's Crisis Talk.
Thanks, David. So I'd like to bring on Kiara Haranilia. She is the program manager for the 24-hour crisis call diversion program, which is embedded within Houston's 911 call center. Kiara, the program provides a fourth emergency response, which is amazing mental health and substance use intervention. And it allows the center to divert nonviolent, non-criminal 911 calls, and also police department non-emergency line calls. Can you talk about the entry points into the CCD and rapid response?
Yes, and thank you so much for having me on. I'm excited to share about CCD and rapid response. So CCD partners with the Houston Police Department. So in Houston, if you contact 911 and you have a non-imminent risk, non-criminal related mental health concern, you could be live connected to a CCD crisis call diversion phone counselor. We'll do an assessment with you, and if eligible, we can dispatch the alternative response team, the rapid response team. They go out with a two-man unit. It's a mental health clinician, bachelor level, and a licensed clinician or a master's level clinician, and they can do an assessment on scene. They are capable of transporting to a higher level of care if that is what's necessary. As we were talking about, the burden on 911 and the emergency departments, these are some of the issues that they're trying to resolve at the onset, at the 911 call, before introduction to law enforcement or going into the medical department. We're available 24/7. Although we are a small team, CCD has a staff of 8 crisis phone counselors and 2 supervisors, and we spread out across the 24/7 timeframe. And rapid response is available 24/7 as well, and they have about 40 teams spread out throughout the 24/7 7-day week. So yeah.
Can you talk very briefly about the Rainbow Care technology? I believe that was added in 2023, is that right?
Yes. So when we first launched the program, we were using emails and Teams chats to kind of keep up with all the dispatching when we were in the project stage. And when we added on the Rainbow Care platform, we were able to collaborate with Rainbow Health and create a platform where we could do call documentation and then also dispatch management for the rapid response team. So the crisis phone counselor is at 911. They're accessing the web version of the platform. And when a dispatch request is sent over to a rapid response team member, they get it on their mobile app on their phone, and they're able to give us real-time app updates, on scene, transporting, dispatch completed, and assigning dispositions and things like that. So it's live time update communication between the 2 units so that we can make our time and dispatching more efficient.
Thank you so much for hopping on with me. And also the matrix is really unique. So please take a look at the article so you can take a look at that as well. Thank you.
Thank you.
Thank you, Kiara. Thank you, Stephanie, and for your ongoing work with Crisis Talk. Next week, we'll have Dr. Morgan Shields, a really great presentation if you were at Crisis Con around inpatient psychiatry and the hope for reform. And the following week, we'll have a fireside chat with the guardian of the Golden Gate Bridge, former California Highway Patrolman Kevin Briggs. You will not want to miss either of those. And let us know. We'd love to come live and on location to your Blue Ribbon program you'd love to showcase for the Crisis Jam community. Thanks for joining us, and we'll see you again next week.